welcome all of our partners in crime here, who basically have been our partners for a number of years in terms of developing advanced cardiac imaging. We've worked together somewhat informally, and we've never really gotten together to talk. So this is a great opportunity to do that at this conference. We are honored and privileged to have our guest of honor, who basically I'm going to introduce shortly, Charles Taylor. We had a great time last night, had some great discussions, shared a lot in common. I guess I'm known more for the application of the latest technology and in terms of being able to shift quickly and make changes, and the adaptation has really been important. I've probably reinvented myself 17 times. And so it's real important in our healthcare industry today, the way it is, to be able to reinvent yourself. And most organizations are so top-down they can't do that. Like we saw on the news, Nancy Seidelman reporting NBC News about the 65,000 ladies who were double-blind, who were randomized study for palpation versus mammography for the detection of breast masses over a 25-year period. And basically, we said, okay, then mammography doesn't seem to be a good thing. And we reviewed that and looked at it. The next day, we said, we're not sending women for mammograms, we're going to emphasize self-examination. Of course, you still walk in the hospital, you see the sign, mammogram, $71. So on and so forth, and nothing changes in that field. Of course, Nancy Seidelman's comment was, oh, it was only one study. Well, let me see, wait a minute, 65,000 ladies over 25 years? What are you looking for? So it's hard for the industry to change, and so, but change is constant. That's the only thing constant. So we're changing all the time. So, my job is to change to the best of our patients and to benefit our patients. And basically, you can see from the handbook we handed out what you all represent. And our latest partner is Hospital Corporation of America, which is the largest hospital company in the world. At least 160 hospitals in the United States, many clinics and many doctors' practices, and 6 hospitals in England. And they're representing a challenge for us to develop advanced cardiac imaging and to interface with the emergency room as a chest pain center, and to be able to do first-line cardiac CT for patients presenting with chest pain for the intermediate risk patients. And if they're inappropriate for that, if they can't have that, or we can't slow the heart rate down, then cardiac MRI. And so that gives us a response of from door to door, going out the door, a 90-minute response time for cardiac CT, which is pretty cool. Don't go any further. And you know, about 50% of patients who show up in the ER with chest pain go home without a diagnosis. So at least this way we know, we can tell what's not wrong with you with the probability of 99.9% negative predictive value. So we're real happy about that. And then the cardiac MRI, we don't have to call it the word of an isotope. It's actually shown to be better than nuclear scanning. And don't think we talk about the nuclear scanning because we'll talk about SPECT scanning and the 40% false positive rate, which is actually modest compared to some centers where we've found centers with, well, we'll admit 50% false positive rate, which is the same as flipping the coin. Or we'll say, certainly there are places with 80% false positive rate, or 65% false negative rate, across Michigan. And so it's a worthless test. Everyone says, well, in my hands it's okay, because I do it well, and I can read around the artifacts. And so everyone's convinced of that personally, but frankly, the emperor has no clothes. And so we all know that that technology is on the brink of failing, and it's about to fall. And there's been a lot of response in terms of venture capitalists investing in areas that they think that would be able to take that fall. And so we've got a group called Diagnostic RX, which is making CAD's Chorus CAD, which is 23 messenger RNA test. and they're getting invested by Fred Cohen from TPG, which is running maybe $6 billion in biotech. And so we got everyone making a play because we all realize the emperor has no clothes. Although the guys in real practice won't admit that, because 30% of cardiology salaries come from spec scanning. And so it's called legacy cardiology. We call it spec and can. Or selling a six-pack is another way of looking at it. And that basically, Fred Cohen said that if a cardiologist touches a patient, it costs $7,000 to the system. And so we think we have the ability to be able to change that as we move into value-based cardiology. And value-based cardiology by the Secretary of Health is going to be a 50% of Medicare patients in the year 2018. So we've all been waiting for the shoe to drop and saying, well, we'll play what there is to play today, which is spec and cap, and make money off of that, and then we'll change tomorrow. And the government's so slow, we don't have to worry about that. And that'll be a day that'll be dawning, but we're not quite sure when. Well, the day is gone. And so it's time for whoever's gotten behind to play catch up. And so we've been doing cardiac CT since 2004. And so I feel like we're way ahead of the game with 5,000 cardiac CTs under our belt and increasing opportunities to do more. And as the radiation gets lower, down to that of 2 chest x-rays, the opportunity gets better because of the risk-benefit ratio. And so we're seeing a lot more opportunity to do this as our vendors are able to avoid radiation. We're very, very happy. So I'm going to make some comments about some of the things that I've been doing lately that have been startling to me that's different from what I did 5 years ago, 3 years ago, to show you how the technology is impacting us in reality. It's not just something you read in Time magazine that you think about in the future. So we say that patients are using their phone apps, which I have one here. They're using their phone apps to send me EKGs, which are rhythm scripts daily. So I'm getting rhythm scripts through the AliveCore system. And anybody we have with atrial arrhythmias, basically, we ask them to get one of these. We're not using the Holter monitors and the cardiac event monitors and all that stuff much anymore because of this. And so Dave, who made this thing, who was a speaker with me on one of the things we did with Spirit Women, explained this, and it's actually, this is an old model, and it's an app you download, and anybody can use it, and you just put your fingers on here and record the EKG, and you have my email address and send it to me. Well, that's huge. It's huge in the industry because there are all these people that bring us lunch, that basically come over with their EKG devices, and they're getting smaller and smaller, but they're looking more and more like telephones, and guess what? So that's a major change, major change. A major change is I've saved my first patient's life by using the internet. That's a big thing. Of course, as a cardiologist, you save a lot of people's lives. You don't remember those. You remember the people that died and the people that hurt you because they died and you felt that. But to save somebody's life on the internet is pretty cool. So we'll talk about that later. I told my first patient that he was going to have a heart attack from looking at a CT scan. Wow. I was amazed. Bob's nodding his head. I was amazed that I said that. It's like the guy who says that's a red Volkswagen, and why is it? Well, it's like a duck. It quacks like a duck, walks like a duck, flies like a duck. And so it is an intuitive sense that after you read 5,000 CT scans and follow up with those patients, and those are patients that we have patient-to-patient contact. I'm not like a radiologist in a dark room seeing scans come through. You for patient-patient contact bypass CTs. And so I looked at that and said, you're going to have a heart attack. What am I saying? Because I've never said that without some kind of functional study, not just an anatomical study. And you can get what I'm saying there, Charles, because that's a limb to be reaching out on and then sawing off behind you. So that was interesting. And the patient did have a heart attack 4 days later, and he didn't take the medication I prescribed. I called someone about doing CT, and because I was so urgent about it, and I called somebody about doing angioplasty because I was so urgent about it. And the angioplasty doctor's medication at Christmas time. He said, well, it's only a 67% lesion, and nobody's even going to pay for it. And we have to lie about it because it's not 85%. Well, maybe, with FFR, we would have known that it's more significant. I don't know. I have FFR. Yeah. We'll have it after this meeting, I hope. And so I think that really was impressive to me. And it's been a year and a half, and it's still, impressive. We have conferences frequently with out-of-town cardiac surgeons, with the patient, the family, and the imaging right in front of us, and using GoToMeeting or GoToWebinar, and we're planning an operation for a patient with the best in the world, and who does more than anybody in that particular surgical subspecialty. And the insurance company's basically saying whether you're the best in the world or it's your first case. And so you might as well have the best. I ask people, do you want an amateur or do you want a professional? My heart. So we plan these things online. And we're sitting around just like we used to do 30 years ago. And I would sit around with Dr. Dennis Capello, and we would have a patient, and the cardiac cath doctor, and the patient, and the family, and the surgeon would be there. That doesn't happen anymore. Everyone's too busy. And so we're going back to what we used to do, which was the way to practice medicine, which is much more personal. That's not concierge medicine for us. That's everyone's a VIP. We are practicing concierge medicine. Our system is diverting into two levels, two tiers. And we've got the Obamacare tier, and then we've got people who want the old-time doctor who's going to be available for them, who's going to come to their house, who's going to answer their phone calls, who's going to email them, and who's going to be there for them and provide them with the support they really want. So that's huge in this country. You see that division taking place at this time, and taking place very rapidly. Because I spoke to the American Association of Private Practitioners, which is the concierge group, and they are eager, these doctors are an eager group to put the new technology in place immediately with people that can afford it. And they don't have to deal with the insurance company and the radiology benefits manager, because people are willing to pay out of pocket for what they need. And we can get a discount. And so that's a key to medicine, is to be consumer driven. And that's something we've been lacking in medicine for 40 years, is the ability of the consumer to make choices. And consumers are making choices every day, because people come in and know who I am that I've never seen in my life. And they've been crawling around the internet going from Eric Harrison to Eric Harrison. And of course there's some that are more entertaining than I am. There's a guy that's a recording artist, and another guy that's a DJ. As an aside, I was thinking about having an Eric Harrison conference. We're going to do it in the Atlanta airport, because I saw all these interesting Eric Harrisons. I said that would be really cool. Right brain, left brain. And one of the things I was talking to Janelle, who helped, Janelle and Christina really helped put this together. Same thing. Okay, and talking to Janelle, I said, Janelle, you know, the great thing about this is you won't have to name tags. And so she was pretty happy about that. You know? Unless somebody cracks the place. That's a different thing. Okay. So we're doing the same thing. We're having international conferences online once a month for the International Cardio-Oncology Society of North America out of our office, and we're talking to somebody in London, and we've got somebody on the beach in Israel. I was in the back of a limo on my iPad in Houston in our conference, and so that's kind of amazing. We got the guy in Poland has been so receptive to our articles. We finally found a journal that published pretty much anything after the Navy deputy editor. So anyway, we're real pleased to be able to communicate like that. That's cool. The other day, I had a patient that needed some lab work in Phoenix, and I sent him to the drugstore. He went to the drugstore, Walgreens, to get a blood test. We needed troponin, $7. We needed a BNP, $23. Go over there, get a finger stick, and the results now. Hey, that's pretty cool, isn't it? As a matter of fact, a couple of years ago we tried to put PCR, where we would have someone that had sepsis and we'd do a PCR and we'd be able to get the information of what the bacteria was within an hour. And we had this capability. I know it was like 5 years ago, and I took it to ISIS, and which not ISIS, but ISIS. Sure it is. What side of the game on cloud? Alright. I took it over there, and they said, we can't afford to do that. Well, Aaron knows, you know, Elizabeth Holmes, Stanford University, your alma mater, you know, in Palo Alto, can't afford to do it, and consumers can afford to pay for it. So can insurance. And so, if I had a patient in my office with sepsis, I needed to basically send them to Walgreens on their way to the hospital to get the PCR. So I'll know what organism to treat after they're admitted, because they're going to do a culture and then they're going to do sensitivity, and then it'll take 48 hours, if not longer. And so, wow, that's a real breakout. You know? That's kind of amazing. And so that's better than American payroll. Breakout. That's like 8 links, you know. It's pretty outstanding. We sometimes watch a live stream of open heart surgery of our patient. We've been doing that for years now. And so, as a matter of fact, one of our cardiac fellows at the time said, it was in color, I didn't know the mitral valve was white. And so, our cardiac fellow, that was the 3rd year, had never seen open heart surgery and seen what the mitral valve really looks like. By the 3rd year of cardiology fellowship. I didn't know the mitral valve was white. Well, and that brings the point that we still got this huge gap between our nurses and what's happening in the hospital and the doctors. And we've invited one of our nurses here from HCA to help us work towards building and bridging that gap. And it's huge. And so I have a patient in the hospital who's going to get Tickerson, and doctors got to take a test to be able to use Tickerson. The pharmacist has to take a test to be able to disperse, to give out prescriptions for Tickerson. And so the nurse comes to me and says, oh yeah, Tickerson, I'll be given that. Is that an antibiotic? And so it's a very potent anti-arrhythmic that you got to take a test for, because for SOD, ventricular tachycardia and QT interval. And so we've got to do a lot the next scan for a couple of years. And so I gave up a bad habit in America called spec and cap. Okay? It looks like it used to be 30% of cardiology salaries were based on SPECT scan. Well, we've totally discredited SPECT scanning except for the journal articles. It seems like the only one that can do it is, Dan Berman. Nobody else can. And I remember when we started this with Bill Strauss and he came to Tampa, he really invented SPECT scanning and planar scanning, and he kind of started. And, it was a very comprehensive, compulsive test. Not unlike dialysis used to be, where the doc was there during dialysis, and so dialysis doc got paid a lot for dialysis because he was actually there. And so we were actually there for our SPECT scanning, and I was the doctor, and we wrap the patient up in a shroud, we take the breast up, we do it prone for nails, we do the stomach out of the way, and we had Lady Mother Teresa, who was very, very, very good, and she was very compulsive. Everything had to be perfect, including laser pointers of where the patient's markers or where the patient's lying when they repeat the test and rest of stress. And we waited for the down to creep, and we did planar before we did everything else. And so it was a very, very comprehensive test that took a lot of work and had the vigilance of a physician involved. And then we get the cap and compare it and have feedback. And so that doesn't happen anymore. That's all been stripped from the program by necessity, busyness, bean counters, whatever. My tech was basically terminated as a dedicated cardiac SPECT scan tech. She was terminated because they asked her if she could be part of a pool of techs. And she could do livers and other stuff because it's more cost effective. And she said, no, I'm a cardiac tech. What are we doing? 28 a day. What do you want in terms of administrating? And so she left. And that day, when she left, I came to work. I was so upset when I heard that. I canceled my office and went to the beach. We had dedicated so much to bring that together. And so the camera moved. The camera was right next to the treadmill. That got moved somewhere. Protocol got changed. Everything totally changed. And then do the stress test, then put them in a wheelchair and wheel them somewhere, and then the belt, I call them body floppers. The most efficient person in radiology in terms of the tech is a body flopper, because your throughput. And better than that is to have a body flopper with ADH, okay? Because then you really can flip it, okay? And so that's cost effective. And so that's what happened to give us a nice round number, 50% false positive, 50% false negative. It's a nice way of looking at stuff, okay? And we were talking about odds once in the flip a coin. And one of my most embarrassing moments in the speech was to hit cardinal sin of spoonerism. And there was a guy by the name of William Spooner, who was at Oxford, who was known for flipping words around. And so I was going to talk about probability. And we were supposed to be talking about flipping nickels. But by mistake, the Spoonerism is clicking nipples. And so that was my greatest faux pas ever. That's called a Spoonerism. You can use that for example. It's probably a better example than to give in Wikipedia because it's more memorable. So what do we need in cardiology? You see what we're doing and we jump pretty fast. Well, we need better workflow. We've got our McKesson partners here who specialize in workflow and help us with something called the cardiology cockpit that we put together once. We need better plaque characterization. And of course, we've got our partners from Vital Images to talk about how can we do that as we have better resolution of our scanners as they improve. And then the scanners, which brings our partners from Philips. How can we do MBIR, which is model-based interleaf reconstruction, which basically gives us the capability of doing a CT scan of the heart with the radiation exposure of 2 chest x-rays. That's nice. How many people in here have ever had a chest x-ray? Okay. All right, well, the chest x-ray, what are they screening for? Well, it used to be screening for TB. You know, a lot of people in the military, don't they get chest x-rays still in the military a lot? Richard? Yeah, they do. Screening for TB. Because you go exposure all over the country, all over the world, whatever. And so how many people have seen a case of TB in the last 5 years? Oh, yeah, good. Good. The worldwide military. Unfair advantage. How many people are partners from McGill? How many people, SOCOM and CENTCOM, how many people have seen a case of coronary artery disease the last 5 years? Okay, so if we could do a CT scan for the same radiation exposure as 2 chest x-rays, and we screen for TB all the time, every day, everyone's had that screen, why would it not be that everyone would get this screen, males over 40, women over 50, the right age group, the right sex, and so forth, or coronary artery disease? Why would that not be? And so, as our partners Philips are able to lower the radiation exposure. Well, we don't have MDIR, we have iDose. We can't even snap on MDIR right now because you got to buy the new piece of equipment and you got to dump what you got. You know, that's always the story. And so we don't even see the prospect of MDIR to be added on to the Philips Bronies right now. But I need that. I need that today. I need that. You know, and I don't need a new Ingenuity. Maybe I can talk HCA into getting that, and everyone will be happy. You know, I'd like to have a snap-on. Looks like you can do a snap-on. Okay? Hemodynamics of vulnerable plaque. That also brings up economical FFR. Somehow we've got to be able to do this FFR beyond, you know, registry, beyond what we can do with our concierge patients. I got people that have paid for $1,500 from the FFR, and but that's the privileged few. If you want to prolong your life, you got to be rich nowadays. And so, as a matter of fact, David Sinclair basically has found after resveratrol in Boston, not Silicon Valley, in Boston. After resveratrol, you know, the next thing was nicotinamide. And with nicotinamide, we said you can prolong your life by increasing that. And instantly you can get the musculature of a 20-year-old. But it costs you, your drug habit would be $43,000 a day right now. You know, hopefully we'll get it down to $1,000 a day. But you gotta save your money, you know? Especially young guys, gotta save your money if you want to live to be 150. Okay? So save it up. Online patient scheduling. Well, we don't have our HCA departments here, they're going to watch the video. They're very busy. But online patient scheduling for anything would help us, wouldn't it? You know?
Yes.
Yes. Okay, so scheduling is a big part of it. Having to say Mother May I to the insurance companies and radiology benefits and managers is a pain in the ass. And so we've decided to go below them by going under the radar, make it out-of-pocket consumer price that's the same as a tire. And that's everywhere. And that's not retail. And that seems to work. And but I've been to the insurance companies and talked to them. I even had Lance Gould call in. I've been to the radiology benefits managers and talked to them. And here's the way the system works. One, the actuaries have actuarial tables. I don't know how you can make up actuarial tables on the specs meeting, the 50% false positive and false negative. They have actuarial tables, and they stake their lives on that. I was offered a job as an actuary for $90,000 when I was a kid, and turned it down because I was an extrovert, and they were introverts. I went to meet the actuaries, and they basically, the way you can tell they're introverts is when they look at you, they stare at their shoes. And the way they had the tip off immediately that I was an extrovert, because when I looked at them, I looked at their shoes. Trying to take the job. The actuaries think this is really important, okay, and that we don't change. And so the insurance companies make $3 per head per unit of time by denying what they call high technology. They drew a line. Because of what the timing was, they drew the line. On the other side of the line happened to be PET scanning, MRI scanning, and CT scanning. Just happened to be on the other side of the line because of when they drew the line. Okay? They drew that line, and there was some validity to it because docs would go out and buy a CT scan and ask for authorization for 30 CT scans a day under death. Who knows where those people are coming from? And that was when we had 22 millisieverts radiation exposure, helical scans, retrospective scanning. So it turns out they say no, it's $3 per head per unit of time. That's saved. And they split that with the radiology benefits managers, in which there are 5 companies, and I've been to all 5. Okay? Don't go there. That doesn't do any good. You know, and basically, what they say is they get 25 cents per head per unit of time. And so that amounts to, for each company, Core Care, Health Health, AIM, NIA, Med Solutions, each one of them gets $250 million a year. So they have no incentive to make a change. They'll have a room like this, maybe 3 times as big, and they'll have nurses sitting in front of computers, you know, with algorithms, looking at the algorithm, you know, and learning the algorithm so that they can say no. Okay? You could do it with a blank screen. But anyway, they're learning how to do that. And then they go home. They don't have to pay them for being there. They go home and they've got, you know, they've got the dog, you know, basically eating the kid's food, and the kid crawling around eating the dog's food, and they've been sipping a Coke, and they're on the phone, and they're talking to one of the people in our office. And they've got their computer screen up. And we can get our computer screen up too, with the same number. And so there are certain keys you gotta learn, like Angelo equivalent is a big one. You know, they can't dodge that one. And it's kind of, yeah, got it. Okay. And so we gotta get permission to do those things. That's in the AI. So the way to dodge that is basically out of pocket thing. But you can't fight it. You can't do that. And so we stay under the radar. Easy transfer of CT data is important, that we can do that. And that goes along with our workflow. I'd like to just bump through some slides quickly, and then we're going to ask Charles to come down and tell us what he sees. And he sees the future very well. And so this is our center, basically, where we have some clinics, and these are our cardiac fellows from Greg, RP, here, and Chris Greg, and so we work closely with our partners at the University of South Florida. They are there. This is an imaging center. It's kind of interesting because we took a regular radiology outpatient diagnostic center. It must be hundreds of them within, 10 miles of here. But anyway, we took one of those and we added what it took for CT, MR, and PET. Well, that's, the radiologist would say over my dead body. We added on what we needed for cardiac. We had to wait 19 years for the radiologist to retire his contract to fade so that we could do that. So then we now had an outpatient private center for cardiac PET, cardiac CT, and cardiac MRI, and we're the only one around, standing on the campus, and there's none like that. Nobody's been, I guess it takes 19 years for a radiologist to retire, and it takes 18 years for a cardiologist to wait for that. And so it doesn't exist. We're the only one. That's kind of interesting. Right, Greg? Yeah. And so that's kind of interesting. And we work very closely with healthcare physicians, and here's our one right down the street here. We work very closely, and we work very closely with presidents physicians in other states, and those are the ones that are prompting us to get CT scans available for them for their practice, and we're doing that. And it's not too hard. They want cutting-edge technology to be able to differentiate themselves as a distinction of the difference from the practice physicians that don't get paid a premium for contact. Because it's not only a premium for immediate contact with your physician, but it's also a premium for content of care. And you can't do a rubber stamp care like the other folks are doing. You gotta differentiate yourself for better care. So these are guys who are ready to embrace new technology eagerly, and their patients can afford it. And so there's our old spec and tap routine. And so I beat that horse to death. And this is where we go off to the side, and you can see that there's a lot less money to be made in terms of, you don't own the PET scanner, you don't own the CT, you don't own the MRIs, you don't get the technical fees, and basically you get paid all your mouth. I think the CCTA down the CT cut that actually. And so there's not a lot of money there. The money basically is in infrastructure and expenses, of course. And so you can see that the entire industry has been geared up for finding a severe obstruction and fixing it. Finding and fixing it. So everything has been moved in that direction because that's where the medical industrial complex leads. Well, what's been ignored is the vulnerable plaque. And so to be able to recognize that 75% of heart attacks come from a not severe stenosis, and they come from vulnerable plaques, and they present themselves with sudden death, or they present themselves with acute MI. Wow, that's not a very good choice. It's like my wife gave me a choice like that once. And my daughter was going to meet me at the old World Trade Center. She was 12 years old. And she was going to meet me by cab there. I was in the Meadowlands. And my daughter gets there, and it's a big place. She's wandering around at age 12. But she's been in Europe, she's been everywhere. And she's on a plane by herself to Europe. And I had confidence in her. And so I did hook up with her and found her. And talked to her on the phone, and before we had a corporate phone. And she was fine, and then she got bored waiting for me. So she said, I think I'll call Mom and see what I can stir up off of the World Trade Center. So she calls Mom, and so then the next phone call is for Dad. Mom. Okay, and I'm going to catch hell, and my daughter knows it. She set this up, and she did it. Okay, so my wife gives me a choice. She said, is it that you're stupid or you don't care? Okay? What am I going to say? Definitely. Any other choices? We're 3 and 4 and 5. I have to say stupid. So, here we are. Here's your choice, a heart attack or sudden death. What be? And so here's the plaque. This is the guy that ruptured in 4 days. We've got 67% stenosis. You don't see the stenosis here. This is upstream from the stenosis. No, this is downstream from the stenosis. Paralysis is downstream from the stenosis. And you can see this plaque that's pointing. We can't tell you if it's in fibrous cap because we don't have the resolution to tell you that. I'm not going to know the difference between 65 micrometers and 85 micrometers with a CT scan. But it looks to me like it's heading that direction. It looks pointy. And then downstream from that was a big hunk of calcium. So I thought, hey, that could give you some reflective pressures. And so there were just so many things that added up on that. And so we're going to have to start looking for these. And they're going to be very important for us to find. And then what do we do to fix it? And this is Charles Taylor's technology. He just can't help but love this technology, because the ability to be able to do cardiac CT and replace the most important thing in diagnostic cath today, because of the theme study, the ability to cross a lesion, introduce with a wire, pressure wire, introduce a Dedison, maximal diesel dilate, and then draw it back and look at the pressure, distal pressure over the aortic pressure, and look at that ratio of less than 0.8, and say that's a significant lesion, and show that if you stent those, they do better, and if you don't stent, they do worse. And if it's greater than 85, and you put 85 and you stent it, it's of no value. And that we were stenting 50%, that we didn't have to stent at all. 50% of the stents we put in didn't need to be there. That's huge, huge impression. And so this technology obviously is going to get faster, it's going to get more effective. I'll probably be able to do it with my phone now, right? What do you think? Heart flow technology. Preparation for CTA, if you've got a slow scanner, a 64 slice temporal resolution multi-plot, you gotta have a slow heart rate. And so basically, as Doug knows, I went to get my CT, and I said, I can't take this temporal. And so I didn't take it, and then I had no coffee, because how am I gonna get up? How am I gonna get to work without my coffee? I won't be there. Coffee, and I go. And then I got to have lunch because it's scheduled at 1 o'clock. And so I had lunch. And then I go over there. Heart rate 73. I fall asleep under the scanner. My heart rate drops to 60 and make the pictures. And so what's the big deal? And then, thanks to Greg, we're going to do a placardiogram. And so we need a moving phantom. And we don't have a moving phantom for a placardiogram. We get the idea that we're going to be able to just do one slice, and all we want is the clot, okay? So that we can pick it up like you do in the dentist's office, and you go in there, and there's the digital picture of Mr. Unhappy Tooth, and we're comparing it to 6 months before, and say, hey, it didn't floss, I know it didn't floss. So there it is, and so we like to do that in the cardiology office. Come in. What about the statin drawer? What about, I thought you were going to spinning class, Mr. Hedges. Whoops. And so, what about your weight? 206 pounds. And so anyway, we pull it back up and look at it. Mr. Hedges is our representative of our patients. He's a patient representative. They're new to America. We've got all our partners here, and he's our patient partner. So basically, we'd like to be able to do that, and so I become a volunteer for that. I get my placardiogram, the world's first placardiogram, and Philips basically assigned somebody to help us make those placardograms look better, because we were doing too much magnification, and it wasn't looking very good, and we figured we can do better. So now we're back on track to do more placardograms, because we've got Philips hand in hand leading us to help us make better ones. So, radiation, same as a dental X-ray. That's very impressive to be able to come in and look at the plaque, see what's happening, compare the necrotic core, compare the fibrosis, see if it's getting more calcified on the statin drug. All that's very important. And so 99.9% negative predictive value, very, very low radiation, and MVIR, the radiation of 2 chest x-rays. And we hope to put that in operation somehow. And the placardiogram is the radiation of a dental x-ray. Price point. We've been able to work out the price point. I mean, if they've got these loss leaders, $49 at St. Vincent's Hospital in Indianapolis for cardiac calcium support. But you got to go in there. You have to have a slow heart rate. People ignore that. They just throw them on there, body blockers. make the pictures. The calcium scores can really go awry. I mean, I saw the lady from Indianapolis who they scored the right coronary 3 times because it moved through the screen, because it was motion, heart rate was bad. So she had 3 times the score on her right. And not only that, but they also kicked in some histoplasmosis, which is from the Ohio Valley. So I just circled across. So a couple of these guys in the bottom too while we're at it. And so her calcium score got pretty high, and then the guy who was chief of the department burned her with 100 millisieverts total radiation of everything that she had, her SPECT scan, her cardiac cath. And then, oh, now we've got to do another CT of the chest because of histoplasmosis. I mean, I live happily with my histoplasmosis being from Ohio Valley. You know, I'm not going to see low-dose CT scan. I don't take low-dose. And so she burned 100 millisieverts in 1 year. The lady has no coronary disease. And just the errorous calcium score. We see a lot of that. That's the chairman of the department, IU. And so the price point, well, we can do this. And how do we do it for $264? Well, it's $199 in the hospital and a $65 reading fee. And the hospital is actually paying by contract an $80 reading fee to the radiologist. And then we got an IV, you can use 250, in contrast with 85 cc's. You don't start the IV if the heart rate is greater than 70, so you got to come back. We won't waste all that, and then we can shoot. And then the patient's tuned up, basically going to get low radiation. We do the picture, and then we don't do post-processing. Because the radiologist likes things straight and not moving. And so they have this radiologist attack. They spend 45 minutes straightening things out and trying to post-process the picture to be able to spoon-feed the radiologist to read it. And so that was a lot of tech time, and we don't need that anymore. And we do prospective, and we only need 75%. And so that gets to be pretty cost-effective. Of course, we have cardiac fellows, right? The cardiac fellows probably get paid $57,000 a year by the university, when in fact we're worth $350,000 a year. But they're getting the credentials from them, and maybe some opportunities in the future, hopefully, for getting a better salary, negotiating elsewhere when they go out to practice. And they're getting on practice on the cardiac cath that we think is competitive. And we think they made a wise choice. As a matter of fact, my daughter made the same choice for advanced training. I think it's positioning yourself for the future. And so this became a very cost-effective price point for us, so we don't have to call the insurance company to say another thing. So I think that's very important. Get through our patients and stuff. I do think it's important characteristics of normal plaque. These are some of our characteristics. Proximity is not listed here. That's very important in terms of non-myocardial risk. Greg will tell you that the OM1 or venous or whatever is going to the capillary muscle is also an important key vessel to keep in mind, because if that goes out, we've got a big loss. Dominance in the coronary artery, if you get dominant coronary artery, that's important. So there's a lot of important things about the plaque that not only make it vulnerable, but they make the patient vulnerable if it closes. Okay. And then no plaque, no worry sounds like something from Nassau. No plaque, no worry, well. And so that's a good thing to know. And then these little pieces of calcium that you see don't seem to be something that's like a forest fire that took place. And there are some stumps that are burned out, and the forest all grew back. And you just got a couple stumps, and there's no burning embers. There's no campfire that's smoldering over there that will start another fire. We seem to see a lot of that. This seems to be some kind of a very interesting disease that will have a remission that may go on for 50 years. or we may have people that come to us and see us every 3 years when they get their forest fire. Logogram we talked about, and this is the cycle, called so-called twin cycle that you might be familiar with. Basically, it's not that old scientists adopt new scientific ideas and theory. Max Planck says it's old scientists die off, and then we can replace them with new ideas. And so you can see. We're waiting for a lot of cardiologists to die off. And so that's what the insurance company told me. I was working with another insurance company, and they said, I said, what do you want me to do? Just wait for all the cardiologists to die off? Yep. Yep. Okay. So even the cardiologists that have a say in the insurance product, and they're partners with the insurance company in cost saving, and basically can share in that cost saving, don't have the vision that if you wait, if you get one marshmallow now, and you wait 5 minutes, you get 2 marshmallows. So you grab the one marshmallow and eat it, that's it. Or if you have the patience as a 3-year-old to wait 5 minutes, which seems like forever, you'll get 2 marshmallows. The cardiologist is not going to wait for the 2 marshmallows, okay? And so they say, no, we don't want to, we're not going to give up spec scanning and CAT, like that. To do, I don't know any training CT and MR. I don't do that stuff. So that's what we're doing. Good cycle, you can see we started out with the angular camera 50 years ago. This is old technology. There's the planar, like Bill Strauss used. And then we went on to spec scanning, and we proved that that gave these beautiful pictures. And so then we went on to flipping waters. I learned all that, flipping waters. And then we went on, to these beautiful scans. This is a 16 slice. Which I started with 16 slices, and we got beautiful images of the SLR. We did great with it. And now we've evolved to plaque recognition or vulnerable plaque. And Dr. Harrison will tell you about looking at those markers that we look at, the inflammatory markers. And we found the 2 that ruptured within a short period of time that we saw out of 15 patients. I don't know how we got that, 2 out of 15. We saw the 2 out of 15 basically had 5 to 6 times increase in their inflammatory markers. We're going backwards. He does the inflammatory markers first, and then does CT. We do the CT, and then we do the inflammatory markers. and so we saw that. And so look what we've evolved to. This is heart flow, and this is where we placed heart flow. And so we have some of our partners here from the military, from the fire department, police department, sheriff's department, Tampa Fire Rescue, Hillsborough County, and basically our goal with them is frequently there is a state presumption that if you acquire heart disease on the job, it's because of the job, and that's legislated. And it makes some sense. Not just to blame the firemen or whoever for their sedentary lifestyle, because we all lead a sedentary lifestyle. Very different from the rest of us. They bring around the firehouse and cook and one block and bring the fires, but there's a lot of paramedic emergencies. But to look at shift work itself is messing with our biological clocks and our circadian rhythms and leads to metabolic syndrome. And the stress of alarms going on, and the stress of waking up in the middle of the night having this gone, and going to bed thinking, I better go to bed early, I know we're not going to do that. And the shifting shifts, and very difficult scenarios in our bodies. It takes its toll, and we take responsibility for the heart disease, and we would like to someday, working with the fire department, police department, sheriff's department, and military, to someday be able to put this under surveillance And so we did 40 firemen, we did their CTs, we found 23% had plaque, and 13% had one vulnerable characteristic of plaque, and one had a high-risk plaque. And so that was our observation. Well, you look at the old data from Korean War, 75% of the young kids had some signs of coronary atherosclerosis. And then you look at Vietnam, and it came down to like 45%, and then you look at Afghanistan and Iraq, and it's only 9%. Well, that explains why in all the studies, the promise study, we're doing all these studies, and we did study diabetes and CT, and Milstein did that, and Solid-C, and they're all predicated on the fact that we're expecting a 9% per year event rate. Well, so all the studies are coming out inadequately powered. They have 1/3 the number of patients we need, or they're followed for 1/3 of the time. And so then, instead of just scrapping the study or following it for the next 3 times that amount, or adding 3 times the patient, you got a lot of money invested, the United States government money and so on and so forth. So you report it, and the report is not being statistically significant. Well, guess what, If you only have 3% event rate per year, and you underestimated the number of patients you needed, it's just simple math, it's a joke. And so everyone's underestimated. Well, look, you go in the military, who do you see smoking nowadays? The military care is superb. Their clinics are great, the doctors are vigilant, the PAs are sharp. And so, totally different from the VA. The problem with the VA is access. It's really access. Computers connect. They got great doctors there. They got good people. It's access in the system. That's inside. So we expect to be able to segue this into fire department, police department, military, if we can figure out how we can manage it and how we can prevent them from being exposed to liability. So that's a key thing. So that's basically my introduction for Charles Taylor, to have him come up. And we can take a little break.